안녕하세요. That's the difficult part of my presentation over. Thank you so much for the invitation to be here. It's always a pleasure to visit your country. I really love your country. I love the people. I've worked a lot with the people at Hira, and it's always a delight to come. So thank you for the invitation. As per the introduction, I will talk about the recent review that the OECD did of the Korean health information system. And I did this, I was part of that team with Professor Nick Klasinger, who spoke this morning, and with another colleague, Gillian Oderkirk. Excuse my voice, I seem to have lost my voice on the flight to Korea this morning, so if I have to pause and cough, my apologies. So, this review, which was published last year now, focused on the Korean health data infrastructure and the Korean health information system. And the particular theme chosen by your country for this review, because there's obviously several ways you can look at such a review, was to improve health system performance. The review was structured as we structure all our reviews of health information systems, and that consisted of interviews with experts and focus groups with experts, stakeholders. This is providers, academia, government stakeholders, and of course patients and civil society. We also conducted some surveys on health data use and governance, and on the electronic health records used in your country, and in fact about 25 other countries across the OECD for comparison. And we conducted a lot of literature and reviewed materials provided to us by our colleagues at Hira. So the theme was performance, but in order to really interrogate that, what do we mean by performance? And I think my colleague, Professor Klasinger, touched on this morning. It's really about how does a system, your system, meet its stated objectives. So how successful is it at accomplishing what it sets out to do? And I guess most health systems have very similar objectives, but they do vary a little bit. And based on our discussions with you and our research, we could really boil it down to three main objectives. Your healthcare system aims to be of high quality, which means obviously safety, efficiency, effectiveness, and timely care. It aims to be equitable in terms of access as well as outcomes, because the two are not necessarily the same thing. And it aims to be sustainable in the face of rising chronic disease, non-communicable diseases, demographic change. It aims to support digital innovation and process innovation to support that. And I think implicit in this objective is the idea of managing rising costs, because healthcare costs around the world are going up. And we need to address this without compromising patient outcomes. So let's look at Korea first, and this should actually say helicopter view 1, but let's look at the big picture of Korea, and let's celebrate Korea for a couple of slides, because in fact your country is a very highly successful, high-achieving nation, and I think you often undersell yourselves in this regard. So let's celebrate Korea. So your life expectancy in 1990 was 7 years below that of Japan, and a few years below that of the OECD average. And you have Japan, the line there is the red line, Korea is the blue line, and OECD is the dotted line. By 2020, this difference was down to 1 year. So that's a remarkable achievement in 3 decades. That's life expectancy at birth. Now, of course, this is not only due to healthcare. I mean, a lot of life expectancy is driven by social determinants of health, education, sanitation, and so on, nutrition. But let's look at your GDP per capita. So again, over the same time frame, you've gone from a difference of minus $12,000 per capita to, at some time in the last 5 years, you actually overtook Japan, and you are now $3,700 ahead of Japan in terms of this metric. So this is probably the reason why your life expectancy has increased so much. But the reason I'm telling you this is to really instill this thought, this idea that this is a country that can do stuff. This is a country that can achieve excellent outcomes, whether it's to do with health, technology, industry. It's a country that does things, that is smart, that values education. So you can be ambitious, you can be ambitious. That's my point. Oh, and you also produce very good footballers. So this guy's a superstar. He's amazing. So when we now look at the healthcare system up close, we find a bit of a mixed picture, okay? And I think Professor Klasinger spoke a little bit about this this morning, but you do very well on avoidable mortality. That's probably because you have so many hospitals, and you have a very hospital-centric system. Your COVID response, as we just saw, was the best in the world, objectively the best in the world. And you have one of the most accessible in terms of access, universal healthcare in terms of that social development goal. You have one of the most accessible systems in the world as well. But the metrics such as self-rated health, antibiotics prescribed, mortality from heart attacks, avoidable hospital admissions, mental health, are all below the OECD average. So in this simple chart, a green means you're above the average, red means you're below the average. And there's also things we don't know. For example, we know the system is very accessible. Everyone can get care if they need it, if they seek it. But what are the outcomes between social strata? And I walked in when Dr. Rayleigh was presenting these data from England, and it presents a very different picture when you break it down by high income and low income populations. There's also a lot of unknowns, so things that are not reported because either the data don't exist or they can't be accessed. And a lot of them are clinical data, as you can see, and a lot of them are very important metrics of performance, of quality. So a good health information system looks a bit like this. It comprises data on public health, on health care, on long-term care, on social care, and as well as contextual data on such as things like employment, economic data, environment, pollution, that sort of thing. So it strikes me, though, that Korea has all of these, or most of these data, but they become much more useful when they can be shared and exchanged and linked between the silos. And that's where Korea can improve, I think, and we'll get to that. Because connecting and linking these data to generate valuable knowledge is how we create a learning health system. And we've heard this theme, I'm sure you've heard this theme over and over again today, a learning health system. It's probably one of the greatest opportunities of digital technology across all industries, I think. Health can really benefit from this cycle of producing data that are produced through normal processes of care, not specifically for this purpose, but then using that data to analyze, generate evidence, and then implement change to improve how things are done. And then the cycle begins again and again. And through this continuous cycle, you are improving the system over time. Every successful industry, from aviation to automobiles, anything, it uses this model. It uses the information it generates in the background to learn. And healthcare has to start doing it, otherwise those objectives we spoke about earlier are not going to happen. But the thing is, imagine trying to do with pen and paper records. I mean, the digital environment where data can be reused as often as possible and they have no mass, they can be shot across the country, across the world in an instant, is just too good an opportunity to let go. I apologize for my voice again. Okay, now what struck me when I looked at the Korean health system is, my PCR was negative this morning, by the way. I had one when I got off the plane. So fresh negative PCR. It's a very unique system. I mean, every system is different. Working at the OECD, you quickly learn that every health system is unique. But Korea, especially because there is such a gap between the central agencies, so HIRA, NHIS, the ministry, the centrally coordinating agencies, and which we could call the demand side, particularly in terms of payment, and the supply side. The supply side is very fragmented, incoherent. The reason I have clouds there is not because the data are held in the cloud, it's because it's a very nebulous system on the supply side. And this translates into how your data flow and are managed around your country. So your claims and administrative data are superb. I mean, they're the best in the world, and they're huge, as we just heard, Dr. Ko. But the clinical data are there, but they're very incoherent. They're held in very small little pockets, programmed in different languages, using different standards. Basically, every provider, just about, every hospital, has created their own electronic medical record platform. And these don't talk to one another. They can't exchange information. They use different languages and coding standards. And this makes it very difficult to deliver good care to a patient who moves around the healthcare system a lot, so someone with multimorbidity. It also makes it very difficult to aggregate this information and learn and assess how well the system performs as a whole. So a lot of the challenges that we'll talk about next are based on how your system is structured, and obviously that's a legacy issue. It's difficult to turn around, but as I said, Korea is a country that can do just about anything, so let's do it. The good thing, though, is that you have excellent foundations. So if you recall, I mentioned some surveys that were done. These surveys are done periodically every few years. And on this chart, we can see the results of the latest survey in 2020 and 2021. On the vertical axis, you have an index of data governance, so how well the data are controlled and managed. And on the horizontal axis, you have an index of your availability of data, maturity, and use. And Korea actually rates very highly on this chart. It's up there with the Scandinavian countries, Finland and Denmark, which are renowned for the way they use health data. Another advantage you have is you have a very strong track record of policy reform. You created the single payer system from a very fragmented demand side system in 2000. That was a huge policy achievement. You managed to separate prescribing from dispensing around the same time. And of course, there's your response to the pandemics, most recently COVID. When you need to do something, things get done. But What's also noticeable here is you have very powerful vested interests at play in your healthcare. So I read about some of the issues. For example, the electronic health cards that were proposed were resisted strongly by the providers. That would have been a good innovation, a good transformation in your system. I heard about the strikes that happened when the prescribing and dispensing laws came in, and also how the giving primary care more of a gatekeeping role across the system was also shut down by the provider sector. So there does seem to be an undercurrent of a lack of trust between providers and the government and the agencies, and also between the public and providers and the agencies. There's not a lot of social license to do things. But let's talk about some of your successes. Now, the drug utilization review has been mentioned, and I noted with interest the evolution of that into the ITS by Dr. Koh. I mean, the DUR is a fantastic system because it's real time. It's how this information should be used. It's very quickly. But it could, if it started to include some more clinical data and data on health outcomes, it could actually become a world-leading pharmacovigilance system, like the Sentinel initiative in the US, where in this diagram, the data that comes from clinical trials, once a product enters the market, it obviously starts to generate real-world evidence, and that real-world evidence is then used to assess the safety of the drug continually, the effectiveness. It can be used to set prices appropriately. It can be used to discontinue the use of that medication in an ongoing cycle. So this is a clear manifestation of that learning healthcare system, and the DUR could easily become this with a few additions and linkages to your to the data it can harness. I read with interest about some of the other, and these are just three examples I've taken from the report of things that I think are really terrific. So the managing non-communicable diseases, chronic diseases. What I like about this is that it combines data from different silos, the silos we saw earlier. So it's public health, population health data with clinical data. It enables coordinated care. It uses that data to enable coordinated care. It provides information to patients, which is really important, so that patients can help manage their own health affairs. And then it also provides that information to researchers who can conduct interesting analyses on it and provide new evidence, better way to do things across the system. So this is another example of something that I really like, that we really like, but it does strike me as similar to the patient management information system as well. So there is a bit of a risk that, because this is such a new world and the agencies are trying new things, there is a bit of a risk of duplication. That's something we would caution against. And the other program that I really found impressive was the Benefits Information Analysis System by HIDA. Again, this combines data from different sources and produces various different outputs. So it really illustrates the fact that electronic data are non-rivalrous. They can be used over and over again. They don't deplete like other resources, and that they really are a public good in that way, and they should be used for public benefit. And some of the results that we've learned about this program have been wonderful. We've managed to make some great changes in the magnetic resonance in stroke patients, thyroid cancer treatment. prostate cancer treatment as well, tracking different interventions over time. Where I think it could be improved even more is if you incorporated some patient-reported outcomes data into those analyses to see which procedures, which approaches deliver the best results for patients using other metrics than death or readmission. And the fourth example is that you have a very excellent and committed research infrastructure and human capital in this country. Some of the people we've spoken to in your academic sector, in your research sector, are absolutely wonderful. And sometimes against very high odds, they manage to deliver excellent and thought-provoking and boundary-pushing analyses, in part because you have such a rich claims data set, and there's just so much analysis that can be done. But we saw again the outputs from the COVID work, from the common data model, this is trying to illustrate, where 40 hospitals have banded together. I think the number might be higher now. 40 big hospitals have banded together and said, okay, we're going to code all of our clinical data into a common model so that all of our data can be combined, and researchers can use it to find better treatments, to find better health policies, to find better processes for healthcare. So this is called the OMOC partnership. It's a global thing, but Korea has really done impressive things. Your hospital sector and your research sector has done impressively. So this is another example of where your country is really pushing ahead and opening new avenues, pushing the boundaries further along. And this really bodes well for creating that learning healthcare system, highly performing system that we talk about. And back to the COVID response, it's really remarkable how well you did with COVID. And of course, it's not just down to how you use data, but a lot of it is down to the fact that your country realized that opening data for use to help save people's lives, prevent people from getting sick, was a good thing, and you made it happen. And you managed the risk of privacy and security at the same time. So it's possible. So this is a slide about some of the obstacles that we found, or challenges, let's say. Now we've spoken about the electronic medical records, the fragmentation there, the inconsistency, although there might be some movement in the right direction on that. There's still, in terms of collecting outcomes data from patients directly, PROMs and PREMs, Korea probably still lags a little bit behind other countries on that front. And these are really, really useful bits of data points to assist with learning, continuous learning and improvement. It's difficult for researchers to access data, especially linked data in Korea compared to other countries. So they do very well, your researchers, to do what they do, but it's not easy. It takes a lot of time and effort. And this is largely to do with the fact that the laws and their interpretation are very tight in Korea, very cautious. And I think this stems from the fact that these laws predate what's possible, both in terms of data use, but also data security and encryption. But as well, it's also the mindset that using data is risky. It's a risk to individual privacy, it's a risk to autonomy. Whereas countries that have gone a little bit further down the track have turned this into the opposite. They say that, well, we have all these wonderful, valuable data, potentially valuable data. Not using them is a risk. By not using them, we actually create an opportunity cost. We could be saving lives, improving lives by putting them to work, the data to work. So it's a mindset problem, I think, in many ways. Collaboration across the agencies and with providers and hospitals could be improved. But nevertheless, we think in incentives for providers especially to invest in technology and infrastructure, as well as adhering to rules, standards, could be a bit better. And then there's trust, which we've mentioned, especially the public seems to mistrust, when it comes to health data, they seem to mistrust that data will be used for commercial benefit, and that data may leak and cause harm in that way. So there's a really big job to do to repair that lack of trust, the trust deficit, and get the social license to start doing very good things with your information. And those people who we interviewed in the end felt constrained by the mandates that their agencies or their organisations have. And this goes back to this idea that the laws are too cautious, that it's a very risk-averse attitude, and that changing that requires leadership centrally, but also leadership from agencies like HIRA. Now, the recommendations of the review are basically the mirror image of the obstacles. So because we're almost out of time, I won't dwell on them for too long, but mainly what I haven't spoken about yet is that there's a need for a unified strategy in your country. So there are so many wonderful things happening at HIRA, NHIS, KDCA, but there's no unifying roadmap to get to where you want to go. So the first thing we thought is that there needs to be a strategy, a roadmap that also aligns with the broader digital strategy for the country, such as Estonia. Estonia did this very well, and they're now one of the world leaders in having a digital society, a digital economy, and the healthcare system is part of that. So legislation, it needs to encourage the use of data for public good while also managing the risks. And both can be done successfully. We've had many examples now around the world of that being done successfully. Access for researchers needs to be simplified, and we feel that a single data hub where consistent access can be provided to the various data that are in your system would be a good idea. Now, this doesn't mean that the data need to sit in that location. It's just a place through which code for requests and analysis may flow. So unfortunately, I've mixed up my slides in my notes. So I've talked a little bit about the last two slides willy-nilly from one to the other. But let me just have a quick look. I think that's just about covers it. I think the collaboration and incentives need to be thought about. And by incentives, we mean helping organisations, especially smaller organisations, with the upfront costs of converting their technology, converting their platforms to ones that can be used as part of a broader system. We would warn against pay for data, and there's a long section on that in the report. And of course, the trust building needs to happen by everyone, from everyone. And there's a box in the report that talks about how trust can be built, and basically it says it has to be done with actions, not words. So whatever you say you will do, you need to demonstrate that you've done it and make that public and transparent to your people. So to sum up, thank you for inviting me. It's always a pleasure to be here. I look forward to the panel discussion later, where perhaps we can ask some questions. You have a great country. You have a wonderful platform to build a great health information system with, and I look forward to visiting from time to time and seeing how well you're progressing. And thank you again for your attention.